So tell me about your T-shirt then.
Well, the one you made me wear. ChariotMS is a trial which, thankfully, I'm not involved in, because you need to be EDSS 6.5 and above. But I think it's really important, because we were talking about it. I think the long story short, and I made this point when you were giving your presentation, I think it's about keeping hand function for people. It's about seeing if you can keep hand function with people with often in the written off stages of MS, so we say, and it's using, in this case, Cladribine. But it's the analogy, like you say, when somebody comes into your room with a power wheelchair and they've got one joystick, you know, in this hand, I mean, I was thinking about a mutual friend of ours, Mark Webb, you know, he's got one not bad hand and one hand which is, by his definition, not that great. I think that's the polite version. And, you know, but the whole idea that if you could preserve that, even for another year, you know, the second you lose hand function, you're completely at the mercy of everybody else. Would you like supper, Klaus? I'll feed it to you. Yeah. Would you like to go to the Luke house? I'll have to do all the business for you. You know, it's disempowering. It stands to, you know, dignity being removed. I mean, things like that are so important for people with MS. It's not even a clinical thing. It's psychological. It's like, I'll do almost anything if I can get another year.
So ChariotMS trial that's underway now since 2021. We're completing recruitment by the end of the year, hopefully. 133 of 200 now recruited. Focusing on upper limb function, focusing on those that have been excluded from clinical trials forever. Right? So this is still the only trial that focuses entirely on this population. We'll see what the outcome will bring. But I think what it already has produced is really a lot of hope and changed, I think, the perspective of many already that, you know, we even in people with wheelchair, we might be able to do something positive with disease-modifying treatment.
But the fact that you even care and are investing time and effort and money in this is hard.
No, and it's wonderful that because it's the NIHR plus 3 charities, MS Society UK, MS Society US, Barts Charity, and Merck as the industry partner have all sort of lined up to support this. So it's all really gratefully acknowledged. So results hopefully out by 2027, right? And what you said about dignity, I just wanted to pick up on that and what people are able to do still with this level of disability. I saw, and literally saw, because we had a video appointment the other day, somebody with an EDSS of 9. Okay, so
9's bedbound, isn't it?
Yes, and so she was operating her phone with her tongue, and has carers coming in 4 times a day, and people and family fortunately supporting. She's absolutely crystal clear cognitively, but she had very little function in any of her limbs, right? So she needs care, but she gets quality out of her life as it is. So I mean, I think we're thinking of, you know, hand function, but we need to really have this broad concept of what is that people, I mean, makes people tick and enjoy life, etc. And that can be really even at that stage. We always, as able-bodied, right, we always have this anticipation where we have this disconnect, as it were, emotionally, this disconnect that, if I'm at that stage, I don't want to live even, or don't want to be so disabled. But as you know, as if you ask people themselves, they do get quality. And I think this is what we are about, that we're trying to preserve that.
I know we discussed this before. I think we've all got different lines, and you're right. At one stage you think about where your line will be, and possibly that changes, and your criteria, etc. But it's this huge thing which I think clinicians often overlook, and not in a nasty sense, but being invested in as a patient. So much medicine is transactional. You've got MS, it's a forever disease. You want a relationship with your doctor. You don't want to go fishing with them. You just want to have this, to be able to, and a clinical trial especially, you really get to develop. I mean, there's, I became quite close with somebody we both know, who, you know, doctor who's just died, Matt Craner. But, you know, it was great just being able to sometimes talk to him about not necessarily MS stuff per se, and you just get this connection with somebody and they care and you have this relationship, and as opposed to you sprained your wrist, do this, take these, goodbye. You know, and then the next time you see the doctor might be for something completely different.
Yes.
But this is a forever thing, so I want to have that.
I mean, it's the nature of chronic disease, right? And so this is if you go into medicine, then you need to be aware of that. Where do you essentially want to be?
But it's where you land. If you end up as an ER doctor, it's all transactional all the time.
Yes, very quick.
You know, but if you're a neurologist, who I think arguably 20 years ago you couldn't do much treatment apart from monitor people's progression or manage it. Nowadays you've got this gift of all these drugs and interventions, and you're no longer this sort of referral service for the patients wobbly on their feet. You know, you're now sort of at the forefront, and then that gives the obligation of, gee, and these people want a relationship with me. You know.
And I think so. Perhaps the final point, important to mention that we're, I mean, what I alluded to with EDSS 9, right here in Chariot, looking at EDSS 6 to 8.5, but also we're looking obviously at people who have virtually no disability whatsoever, right, in attack. So that we're trying really at every level to squeeze out the optimum of what life can offer, as it were, at that stage.
That's the other end, isn't it? I mean, that's essentially attack is about the first 2 weeks you're displaying MS symptoms. It's Natalizumab, isn't it?
Natalizumab.
Yeah, which is a reversible. So let's just say you think actually might not be, and we were talking about occasional misdiagnosis. At least, unlike say, I don't know, Ocrelizumab or Alemtuzumab or something, which you can't really turn it off that easily. Natalizumab doesn't have any lasting, but it's, how was it described to me? It's like a sort of ring of defense around the brain.
Yes, I mean, it blocks access of lymphocytes to the brain.
But just to think that somebody went, right, this is a forever disease and we're going to go chunk now. Not, as a patient said to me on the channel, their doctor said, oh, come back when you're falling over. And you're like, gosh, you sod, you know, I did this person, by the time they're falling over, is going to have suffered an irreversible amount of disability. Yet you could have potentially said, do you know what? Would you like to try and like knock this on the head now, not when you're falling over?
Yes, I think there's a true lack of urgency in the secondary prevention. This is what all we do is secondary prevention, because nobody gets treated as a primary preventive, because if we don't know the cause of MS, or even if we knew, even if we were 100% confident it is EBV, we don't know how to approach it. But
what's the cause of cancer? But you say cancer, everyone throws their hands up, there's a pathway, there's a protocol, it's all done. MS is like, oh, might see you in 3 months, you know. You can't imagine that with a cancer.
What we need is a 2-week pathway similar to cancer or rheumatoid arthritis that people, get into. Yes, stroke is obviously super fast, quicker, but yeah, we managed. I mean, 11 patients so far. We've enrolled in ATTACK, and hopefully we'll get more.
I mean, without over-egging it,
complete that as well.
You could well have changed the life or the life outcomes of many people, you know, in ATTACK. And I mean, I've had MS 31 years. There were no drugs, you know, but the whole idea of, I look at where I am now at the tender age of 55 and thinking, if that had existed when I was diagnosed and somebody had said that, and then I'd gone from 23 to 55, would I even be, I mean, I'm on a cane sometimes and stuff, but it's just, you just think, wow, wouldn't it be great? I mean, it's a sort of, it's conceptual.
Yes, and I think for the new generation of those who are developing a condition now, they're clearly in a better in a better situation than 30 years ago, when treatment only.
You hope, not everybody, and I've been looking at some of the figures and stuff, and you think there's still places out there which are doing the come back when you're falling down. We might give you beta interferon. It's just like, why would you do that?
Yeah. I mean, you alluded to the heterogeneity of sort of service distribution and acuity, urgency in it. Yes, clearly. But I think this is a key element that we need to work on, right? No, honestly, I think that whilst we're obviously developing medications, etc., I think what is key is actually to try and change the approach of our colleagues, mainly educate the public, with an emphasis, I think, on people who have MS themselves, because their relatives are obviously more at risk, to recognize early signs, etc., and thereby, you know, mitigate and reduce the overall burden of the condition.
I think we need to look at, as a medic, you have been trained in a way that were somebody to present to you with what you suspected was stroke, you immediately start running a 4-hour clock in your head. And you don't have to be a good or a bad doctor. It's not it's a protocol for treating it. But that doesn't happen with MS. There's something doesn't do that in the doctor's head going, right, so now we're looking for speed now of intervention to prevent. Yes, it's not as that 4-hour window, but 2 weeks is.
No, it is clear that.
But it's the attitude.
Yes, it's the attitude, and I think to a significant degree that is actually driven by people like yourself. Like, no, honestly, I mean, people with the condition who are able to, you know, advocate, you know, for themselves and others to use, in a way, also the, you know, NHS Constitution and other sort of instruments to make their case, and thereby help changing, as it were, approach the field, whatever you want to call it.